that have, yeah. Got it. Thank you, Mike. um, we're trying to take advantage of the podcasting medium. They're about 20 minutes in length. We always do a transcript. In many cases, we add maybe an infographic that go along with the podcast. But you can see from here, we've really started to branch out with the number of podcasts. At our annual scientific meeting that was just held in Tampa, those are the ones that have the asterisk against with them. We had a program on kickstarting the brain health conversation with diverse cultures. And so we took advantage of having those individuals with us who were talking about these topics and got them on a podcast. And they're really meaningful. And you're talking with the top experts in a manner that's a short snippet and get you what you need and get you on, helps get you better acclimated. A lot of times the questions are, what is dementia and what is normal? And so in the kit, there's a letter K3 that talks about learning and retaining and solving problems and reasoning and spatial ability, language and behavior. And what Alzheimer's Association has done is continue to expand out on signs of dementia and typical age-related changes. I think these are normal types of questions that people have, and this two slides here go deeper into this, and it gives you very easy way to communicate with family members and others. I have to tell you, I am 64 years old. My brothers and sisters are in their 70s. And my husband's family's in that age, and regularly conversation is had on this particular topic, and unfortunately there's some ageism associated with it and some conversations that aren't so friendly about it. And I think being able to weave these typical changes and other changes into conversations, it's changing one person's mind at a time on how to approach not only the topic but also ageism as well. That doesn't look, can you see all that? Yeah, that's pretty good. Yeah. I just can't see with my glasses. So these are resources that help bring the topic of brain health so it's less stigmatizing. You can see the resource, the people who are resourced here are referenced: McKnight, CDC, NIH, and Alzheimer's Association. And become familiar with them and determine which ones that you find most valuable. But this is a really great list. We're doing a lot of work with McKnight right now. I'm very excited to see what they're doing in Florida, and I think more to come between us and McKnight. The NAPA, the National Alzheimer's Plan Act, just about a year ago, added another element to their goal list, and that's on risk reduction. And this whole topic of risk reduction really wasn't that much on the radar about 10 years ago. And it's super exciting to see that it really is on the radar and it's very meaningfully addressed. Just the fact that it's added to the NAPA plan illustrates that. Us Against Alzheimer's has done some meaningful work on this, but I'm sure you're all very familiar with these issues here, but the issue of getting enough sleep, it is very much in the press. It's no longer a badge of honor. Oh, I only slept for 4 hours. That's sometimes me, and I know sometimes I used to say that. It's just not very healthy, and even our own publications at GSA are dedicated some serious press time to this topic. Staying socially engaged, I think, through AARP and others, the issue of social isolation and dementia has really gotten really high attention. I believe the Surgeon General has even addressed this as well. So these are really important things. And so when people say, oh, there's nothing that can be done, there's a lot that can be done throughout your life course that can promote brain health that are very, very meaningful. So there we've gotten through the letter K. And that is, as I mentioned, a super amount of good tools and resources in there. But then we move on to assess for cognitive impairment. Now, when the work group was putting together these tools and resources, one of the biggest conversations they had was, does this go under Kickstart or does this go under Assess? So there's a bit of fluidity between these two top titles. So don't think that the KAER Toolkit is, you must follow this and do it at this point in time. We're not intending that to be that way, but just know that there's things that can be done at one point, even though it's at a different point in the toolkit. But use a validated brief test, determine if further evaluation is needed, and emphasize that whole team participation. In the kit, there is an example of how medical assistants were properly trained and provided some much needed sweat equity within the practice setting, and identified individuals who may not have been identified in a prior manner. So using that whole team is really important. And we'll continue to add more case studies into our kit. So this is table A for assess A1 for the first one. And these are listing different cognitive screening tests. I'm often asked, oh, what do you think is the most important test to use? I can't tell you which one to use. I can just sort of tell you what I'm hearing that people are finding that they're using at this point in time. And that still is that mini-cog. The issue of languages is one that is a conundrum, because the mini-cog has lots of, in their website, many that have been translated by different individuals, but not necessarily validated. So know that those are available, but everything has to be taken with, will this work for the population that I'm working with? I hope that the opportunities to have many of these tests validated in different languages grows dramatically, and we will add as many as we can when they get into the system. Now going to the family and the informed, those who are around the adult, and then going on to the older adult. It's really important to engage the care provider in answering some questions, and because they're the closest and can observe some of the changes, and not only just the memory changes, but also some of the behavioral changes. And sometimes those are the first ones that are seen, and that would be in the Behave, which is the neuropsychiatric questionnaire. But these are still among the tops, and we'll continue to look at. Has anybody had any experience working with any of these in this room? Okay. They're not hard to do. I would get acclimated with them and the kinds of questions that are in there as you're working with others who might say, I'm a little bit worried about Aunt Mary. So it would be good to take a look at these tests. Another thing I don't think I mentioned before is Us Against Alzheimer's created a thing called the Brain Guide. People are saying, oh, I'm so afraid that I'm going to be cognitively impaired. Well, this Brain Guide gives you a chance to go through a battery of questions to get yourself grounded. Are you a person that might need a little bit further discussion with your provider, or are you really kind of okay? And millions of people have taken this Brain Guide. It's very easy to do, and kind of gives that little check off that I'm okay, because I don't know any older adult who doesn't have this big fear, right, Patricia? Yeah. And then the self-reporting of cognitive decline. The older adult with some cognitive decline may not be able to pick some of the subtle signs, but seeing how they respond gives some insight into where they're at and what they're thinking about. It's an important tool to provide to the individual. They want to know, and they want to see, and they need the answer, and they deserve the answer that they get. It's important to understand people's perceptions that how this individual perceives themselves. Okay. So then moving on to E is the evaluation for dementia. And it's important to have a meaningful diagnostic evaluation. We rule out reversible causes, and that word reversible has a bit of controversy, but those are issues related to drug therapy, sleep, social isolation, so things that might be modifiable, and some are in fact reversible, and then conduct or refer for a full diagnostic evaluation. So let's say there is a bit of concern, and so the discussion of let's go take some more tests needs to be conducted in a very meaningful and thoughtful way. And we provide some ideas in the kit on how to do that. Conduct the diagnostic evaluation, identify the cause, document the diagnosis, disclose it, and when indicated with permission, share that information with the trusted friend or family member. So let's look at that a little bit further. Here, the work groups put together the components of a diagnostic evaluation for dementia. So it follows what should the PCP do, or what can they do prior to a neurologist referral, or what should a neurologist be doing. Now this is going to be seriously updated. Things have moved so quickly over the last year and a half related to blood-based biomarkers, which is going to put the issue of the primary care physician in an even greater role. You know, 2013, we knew that the workforce wasn't ready, and we still know the workforce isn't quite ready. And it became even more prevalent that we weren't ready with the first approval of a disease-modifying agent. What's even going to force us even further is the opportunity for blood-based biomarkers. So with this issue, with a blood test, we're working in the field to ensure that there's appropriate standards for the test. There's tests out there that people get results and they don't get any counseling. How scary is that? And inappropriate could that be? But they're working really hard on what should these tests say? How should they be said? Who should be communicating the results? We're really working on looking seriously at that readiness factor. You know, how ready are the PCPs to be engaged in this issue of blood-based biomarkers? And do they even know what this is? And then how are we going to manage it within our own practice setting? You know, that's the really biggest issue. So we'll be on this a lot over the next year, working with other organizations, but it will probably be a game changer. It's exciting to see. Even the delivery of the medications that are available, who provide more functioning for a certain period of time. There's no cure, but there's even change in delivery mechanisms of that right now. Leqembi is infusion, and it will likely be an injection, you know, home-based injection. So the data on that is actually really good and really exciting to see. And so that as things continue to evolve for the treatment or the care, you'll see the importance of the primary care provider escalate. Right? You're nodding. Oh gosh. I mentioned earlier the behavioral issues that care providers often see before they start to see some memory deficits. And those are, you know, the dementia-related psychosis, the pseudobubbler effect, the crying, laughing uncontrollably, and then the agitation in Alzheimer's disease. You might have heard a lot about that most recently because the FDA approved a product for that this spring on agitation. And it's very real and very frightening for your care providers to see this because they're not used to it. People have a change in personality, and that's oftentimes the first situation. So I'll give you a little behind the curtain on Karen Tracy. My daughter suffered a brain injury from a virus when she was 8. And so she has, her brain got injured from the viral encephalitis. And so she has seizure disorder, but what's more complicated is the behavioral disorder. And so when I work in the area of Alzheimer's disease, there's many areas that I can personally relate, but this issue of agitation is so real and so complicated and so hurtful, because the person that you love and dedicate so much time and effort to isn't the person that you know. And so we continue this journey of our family. She's now 27 years old. This happened when she was 8. So we've been living with it a long time. But learning how to work the healthcare system, learning how to have meaningful conversations, those meaningful conversations are golden. And if we can ensure or help our workforce be better communicators and be better adept at what the tools and resources are, we'll have a much better outcome all in all. So I personally have good days and bad days, and I live the caregiver journey. So it's okay. There's good things and bad things, right, on everything. So in the kit, we have a comparison of conditions for DSM-5 diagnostic criteria, information on what's caused by Alzheimer's disease, the vascular conditions, and Lewy body dementia, which I believe is where one of those two is Bruce Willis. And in fact, one of our journals at GSA has an editorial about what celebrities do to raise awareness on different parts of Alzheimer's disease or different diseases, and how hard it was for him, who is very well resourced, to get an appropriate diagnosis, and the challenges his families face as they go through this journey. So we publish a lot on the issue of Alzheimer's disease, as Patricia knows. The resources on how to diagnose dementia are really quite nice in the kit. There's different videos which I think are so meaningful, and we hope in 2024, that's what the year coming up, right, to do a lot more videos because they tell a full story. We have good colleagues down in Georgia at Emory who are doing some amazing work. That the state of Georgia is doing great work, as well as the state of Ohio. But the idea of doing a lot more videos is where we're going to be focusing some more of our efforts, in addition to doing the podcasting. The whole kit is going to be overhauled in 2024 as well. So now's the time to say, hey, Karen, I think this is really good, or you're missing the boat on something. So simple talking points, videos are really going to help. Let's see, make sure I don't get anything here. And then the final part of the kit revolves around the referral to community resources, and wherever you're at, whatever you're doing, you're the one who's going to need to make sure that you have a good understanding of what is in fact available. And there's a lot. There frankly really is a lot, and it's growing and actually very meaningful, the resources that are available. But it's not a one and done. In this disease, and with older adults, there's many other chronic conditions. So it's ongoing support. It's not just you're out of here and you're on your own. The education and support and referrals is really important. And we also have a section in our publication on how to participate in clinical trials, which I think is really growing a lot these days. I mentioned that internal staff, lots of people within your practice setting can have a role. You might be working with somebody for a long period of time, and all of a sudden they start to miss appointments. So these are things that just need to be aware of and get individuals to the right person. As I mentioned with Emory, they use a risk-based approach. They conduct a comprehensive assessment, and the care planning is then led by whatever team member is most appropriate at that time. And then they make external referrals as appropriate. So it's really, I'm seeing more terminology of patient navigators and care managers. The terminology has been used in oncology a lot, but I think this is still an emerging terminology in this field. Wouldn't you say, Tricia? It's emerging. I'm glad you're sitting right in front of me. Yeah. Let's see here. Okay. There's a variety of types of referral forms that are in the kit and accessible. You know, things are what you can do leading up to your appointment with your neurologist if it's needed. There's many things that a primary care provider can do. We're going to develop more information in the kit on here are the things that your PCP can do before you get to that neurologist appointment. If you think that the PCPs are inadequately prepared, the neurology field is inadequately prepared as well. Because they don't just deal with Alzheimer's disease, they deal with lots of different things, and they're not dedicated just to this particular area. And that workforce isn't fully ready yet. And so the better we can care for individuals before they get that specialist appointment, I think the better we're all going to be, and treat people with dignity and kindness. There's a very good podcast on the interdisciplinary approach to community referrals. So what I wanted to say as I close, I'll just get my notes here because it's brilliantly said, is that there's a few things that I want you to remember as I leave here today. Is it's important for all of us to try to normalize the brain health conversation earlier in the life course and familiarize yourself with the risk reduction activities that are available and appropriate communication with older people. Some of the resources in the kit are ours, and ones I'm real proud of are the ones that refer on how to effectively communicate with an older adult in a non-ageist way and help them through their journey. Assess your setting to determine the tools and resources that may be viable for you and your colleagues. As we're out socializing and training, we're capturing some of these case studies and we'll be putting them in our next kit. If you're a practice setting of 5 people, this might be the best set of tools and resources for you. Things of that nature without, just to give you a jump start at getting to try things. Maintain a can-do rather than a can't-do approach. There's many things that can be done for individuals who are in the early stages of their cognitive impairment journey. And I hear horror stories of individuals who are doing nothing and family members who have a defeatist attitude. It just breaks my heart when I hear these stories. I heard one just yesterday because a gentleman just can't get his sister-in-law to move off the dime for her husband. And I think the more we can normalize brain health, the less we'll hear of these stories where people feel there's nothing that can be done. If we could ask the question always, do you have any concerns about your memory? That'll be a great thing that we can all implement. And finally, as this environment is rapidly evolving, keep us close, keep GSA real close. We need your input and we need your guidance, and we'll be regularly updating the kit, as I mentioned. I think one of the things that is on our radar to do is to help our readers and users understand the huge amount of research that's being done in this area. Nobody has time to read the hundreds of research papers that are coming out on a monthly basis. But there are some that stand out above the crowd. And so we've been asked to do some of these, the Cliff Notes, somebody remembers the Cliff Notes here, to do this perhaps on a monthly basis. What are we hearing and how does it apply to the care pathway? So I say thank you and ask if you have any questions.
I have a question.
Great.
Do I need to do that?
Yeah.
Our vehicle. participant.
Thank you. You're the first one in and the first question to be asked. It's awesome.
Thank you, Karen, for that. Really very enlightening, with an Asian parent, that's really helpful information. As a physiologist, I'm really curious, when you had your slide on about all the behaviors that can help improve brain health, strength training was missing.
Okay.
And I'm curious if that's just the lack of literature. I mean, strength training behavior is imperative. I personally don't know the connection to brain health and strength training, but I know it improves so many other things as we age. I'm just wondering if that was purposely left on.
And there is strong evidence, like strength training and cognitive, people are almost people.
Yeah, I feel like practitioners should be not only encouraging that workouts, but strength training, physical convention, and all of that. So I'm just curious if that's something you can touch on or add to your slide.
I think we can definitely add to the slide. This is why I love being out here with everybody. We get the issue of strength training a lot with our obesity and overweight program. There's such a big concern about sarcopenia and losing weight too quickly and losing muscle mass and not the right thing to lose, and strength training and gait and that. So I'll bring it to the team.
Yeah, the American College of Medicine probably.
Yep. Very good. Thank you.
Great.
It's awesome.
Hi, thank you so much for the information. I had this toolkit available to me, and this is so helpful. Of course, you need to go through it and really get more familiar with it. My question has to do with kind of a bigger picture. What is GSA doing to try to recruit interest in working with the older adult in medical school arena, or in healthcare in general? Is that it's such a big resource, but we need people to give it to.
So the question is primarily on the workforce.
Yeah.
Okay. Well, that's a huge issue, not only for the geriatric field, but across all the professions. We take that seriously and have since the first report came out. There is an Elder Care Workforce Alliance that has a dedication to this. There's the Careers in Aging Week has been expanded to a month to broaden that issue, the importance of it. I think the more we do to change ageist attitudes and make working with older adults really sexy and really cool, because it's so complicated. What student doesn't want to work on complicated cases? That will help too. Recently GSA was awarded a grant from NIA, Resource Centers on Minority Aging Research. And many of those centers are dedicated toward bringing individuals into the fold from culturally diverse backgrounds to be researchers in this field. And many of them are in the area of Alzheimer's disease. Now, it's not a recruitment tool. You know, GSA and how this coordinating the centers, the individual centers are responsible for helping to stimulate interest. But this is a huge thing to tackle. It's not one that we take lightly. So if you have any ideas or want to be on a task force, interested. I also know the manufacturers of Alzheimer's disease products know how big this issue is. So if you remember a couple of years ago, many years ago, there was a real nursing shortage. And Johnson & Johnson got behind this and really put some serious funding behind driving more people to want to become a nurse. And it helped. I think there's still serious issues, but it helped. But the pharma manufacturers of these disease modifying products, you know, I work with them on a daily basis, and the people I work with are so committed. They just want more people cared for the right way. And they may have some funds to help us with that.
Now that you mentioned the minority community, how is promoted it within the minority community?
The kit has been promoted. Let me put this way. we spent a lot of time in 2023 pounding the pavement. Okay, so for a couple of years, this kit was the Karen Tracy show. I was a big advocate for it. We didn't have funding for it, and GSA was committed to it because we felt the tool was very valuable. We now have some serious funding to keep it alive, to keep it current and pound the pavements on it. So this past year, we've had meetings with the Indian Health Service. We've had meetings with Indian nurses, like from not Native American Indians, but Indian nurses. We've presented it there. You saw the diverse communities kickstarting the conversation. So we have a good relation with the Alzheimer's Association with Carl Hill, the Black community, the LGBTQ community, the IDD community. It's a huge issue, especially when you look at the Native American. Each tribe has its own culture, and there's a different approach. There's people who are on the reservation and people who aren't on the reservation. So what we'll continue to do is socialize it the way that we can. In 2024, what we really want to do is get into systems, roll up our sleeves. That's what we want. And I think people see the seriousness of how we take this. My coworker is a nurse and she's a dynamo. And we just go wherever we can go. We don't ask any funding because we've had funding to keep the KIT program going. So if you have places you want us to go, people you want us to see, just let us know. We will do it. Yeah, getting access is the key there.
It might be interesting to add from the working group, someone from the Hispanic.
That's a great idea. We do work with the Hispanic group with obesity, but so what we'll do is we'll make a connection. The rural community is the National Grange, and I'm excited they're represented by the National Grange, and I'm super excited to tell you that in the first quarter of 2024, you'll see an article from GSA in there by my colleague Jen Pettis, who will tell you she's a nurse every time you see her. I kid her all the time about it. And that one's on obesity and overweight, elevating the fact that it's a disease. And they have asked us to be a regular contributor. So that's very, very big. And so we're trying to tackle as much as we can.
I think other professionals using this, like, did you see dentists?
Yeah, you'll see in the kit that University of Minnesota had a grant with a couple other groups, and so dentists spend a lot of time with patients, and as do a lot of other people, but getting the dental community sensitized, because they'll see patients for years and years and years. They're a lifelong patient regularly, and they could see changes, maybe more than the PCP, but there's tools and resources in the kit that go to this particular program, and they're really good stuff. Really, really good stuff. Yeah, I run the oral health initiative at GSA as well, and you may not know this, but your mouth is connected to your whole body, and it's one of the things that I was trying to showcase a lot. And even issues of what's happening in your mouth certainly affects dementia.
And actually, I was not say, part of the oral health should be part of those.
Yes, you're right. Probably it should. Yeah, that's a great idea. I love this group.
We have a couple of questions in the chat.
Okay. Yeah.
So one is, the diagnosis addressing social isolation, which we know from the pandemic, especially impact cognition.
That was on one of the healthy brain initiatives. Social isolation is in fact on that slide.
Is there a way to give the KAER Toolkit?
A way to get it?
Yeah.
A hard copy? Or it's online and you can download it.
I think because we didn't put in the chat, maybe.
Okay.
So my he's gonna have that.
Okay, great.
And as a researcher working in this area, what is the process of using the KAER Toolkit in an upcoming grant proposal?
I love that question. We're very open to it. The CDC grant for the University of Washington was a collaborative grant. And so we were on the calls with the University of Washington regularly and provided guidance and resources for them. And we presented at the Alzheimer's Association International Conference. So love to have a chat. Love, love, love.
I'll send you an email.
Okay. Okay, Tracy at geron.org.
I already wrote it down.
I see there's a couple questions in the back.
Yeah,
Does
I
it-
have a question. I'm sorry. Okay, so.
I work for a local nonprofit, and often we get calls from people who are caregivers for people living with dementia, trying to understand what local resources are available to them. And we work very closely with our area AAA. But there isn't, I'm big on plans, having things like spelled out for, you know, in this situation, this is what you should do. And so I'm very interested in the section of toolkit related to community resources. And we're planning a meeting in January with our AAA and other local support groups for people living with dementia, with the idea of coming up with a plan, having okay, if this is the situation, here's where you can get a caregiver support group, or here's where you can get, you know, other resources to help you get through this. Is there anything specifically? I haven't been able to connect through the toolkit to anything specifically about here are the basic things that everybody should know about if they're dealing with support for somebody living with dementia.
If it's in there, it's a reference, but if what you come up with, I would love to see. I would love to include it. I'd have to take a look at it because there's a lot of resources out there where I think we struggle is because I can say contact your area agency on aging. I feel that's pretty lame personally. But that's what I can do right now at the national level. But that's where I want to start to get some of those specific case studies on how people are employing this approach in their own environment. So people can mimic it. So I don't want people to have to invent the wheel.
Yeah, because I mean, so often we get people that come in and they know that their person that they're supporting is living with dementia, and they've done the analysis part that you're describing.
Yeah.
But then they'll say, so now what do I do? And the best thing that I have found to give people is from the Rosalind Carter Institute on Caregiving. We have a giant book, I've been training about already before COVID. On their resource book for, you know, how to address specific situations that people living with dementia experience. But it's a book that's about this thick. And it's wonderful, it's very comprehensive. But then plugging people into the local resources that we have available in Alexandria hasn't been defined yet. So we're trying to do that. But if you haven't looked at the Rosalind Carter Institute and Caregiving for people living with dementia, I would recommend.
We'll definitely add that. Georgia is awesome. The state of Georgia, she's there in Georgia, or center's there. Thank you. Appreciate that. I think there's one more question, then I'm running late, I think.
I know this is very unusual from this state. Is it in case if someone wants to use a GoFundMe, transcribe translation.
Any tool that we were able to find that has a translation is linked on there. So the MOCA has a whole bunch of translations there. But I can't say that they've been validated. Okay, so it might be this particular county or spot in England or something of that nature. Someone took it and translated it and then brought it back to MOCA, and it's up on there. So it's not, may not be all the right words to use for every, but there's a lot in there for a MOCA.
Well, I'm only gonna have one, not so much a question, but a comment, like, how important initiative in terms of workforce and preparing people to use and even for work training students and other healthcare professionals. What about the development of, in addition to the toolkit, but also like models how to train, going back to the workforce training, or to train future professionals to efficiently use and learn more about it in the ways more implementable.
That actually is on our work plan for 2024, so thank you for teeing that up. We were able to launch our own learning management system at GSA. And so that allows us to have modular education and modular training where that provides opportunities for, short tests and quizzes that can bring you along the way. So we often get, oh, is there CE associated with this? I'm not a CE provider, but I'm going to see how we can become more of a CE provider. With 26 different disciplines, there's no way we can be a CE provider, but I can work with outside groups to add some things in there. But we'll definitely be working on a curriculum moving forward, and I'll ask for your help to how to make that happen.
Thank you so much. We are on the over and all the time. But I want to also acknowledge our wonderful speaker. We have a very real appreciation for you.
Thank you very much.
You don't know how the people working at GSA, how busy they are. They're at Congress, they are on the council, they are constantly advocating and representing us for really making aging the best quality of life and the moment, the physical life. So we have tons of appreciation for everyone at GSA, especially for you, caring for so long, so committed to the cause. So we have a certificate of appreciation.
Oh, thank you so much. Thank you, sweet.
Just a little
Nice.
contribution.
Thank you. Thank you. I really appreciate all the questions. Thank you. And I knew when I was looking out, everybody was paying attention to me. So that's happy holidays. Thank you, Mike. Thank you. Am I off camera? We're here.
Yeah.
I have my card here too. That thing called a business card. Remember?